Assalamu alaikum everyone, Bismillahirrahmanirrahim. Uh, my name is Dr. Hassan Hassan and I would be presenting today's journal club. It would be an introductory session on renal mass, clinical presentation and evaluation. Our learning objectives for this presentation would be at the end of this presentation to have some knowledge about epidemiology and risk factors associated with the development of a renal mass, to understand the clinical presentation of a renal mass, signs and symptoms of initial presentation, and how do we investigate the patients initially, the basic laboratory workup, and the radiological imaging. To understand a group of disorders called as paraneoplastic syndrome, staging workup of RCC, and indications and technical aspects of performing a renal mass biopsy. Starting from the epidemiology, according to 2018 GloboCan data, an estimated of 400,000 people a year are diagnosed with neoplasms of the kidney that constitutes roughly 2.2% of all cancers. Out of these, approximately 250,000 cases are diagnosed in males and rest are diagnosed in females, which make the male to female ratio of 1.7 to 1. North America has the greatest incidence, with Western Europe and Australia not far behind. Belarus, a European nation, has the highest incidence of renal neoplasms in the world, with 16.8 people out of every 100,000 people suffering from the disease, while many Central African nations have an effective incidence near to or equal to zero. Specifically, RCC is the seventh most common form of neoplasm in the developed world. Uh, and the surveillance, epidemiology, and end results that the SIUT statistics reports that in the United States, about 74,000 new cases of kidney cancer were diagnosed in 2019, accounting for 4.2% of all cancer diagnoses. The incidence was first reported in 1975 as 7.1 per 1 lakh people, and in 2016 this resulted in an incident rate of 14.9. So this was a steady rise which was almost double compared to 1975. So it makes kidney cancer one of the fastest growing cancer in the United States. Now, coming to risk factors associated with the renal mass, they can be divided into unmodifiable and modifiable risk factors. Unmodifiable include age, sex, and race. And amongst the modifiable risk factors, we have smoking, obesity, diet and alcohol, hypertension, occupational exposure, and few drugs that are associated with renal tumors. The average age of diagnosis in United States is roughly 64 years. Though most patients are diagnosed between 65 to 74 years, interestingly, those patients which are diagnosed with VHL disease, that's the von Hippel-Lindau syndrome, they develop RCC at an age of 44 and are they much more likely to be diagnosed with bilateral disease. Like most neoplasms, RCC is most common in men, with men accounting for about 2/3 of global cases and deaths. We just mentioned the ratio between male to female is 1.7 ratio 1. A part of this increased risk may be explained by the greater rates of modifiable risk factors that are more associated with men, such as smoking, hypertension, and obesity. Uh, in the United States, African Americans, Hispanic, and Native Americans have a greater risk of RCC than the white Americans. And there's also some specificity to the subtype of RCC. The clear cell subtype is more common in Caucasian Americans, and papillary subtype is more common in African or Caribbean descent. These were the unmodifiable risk factors. Among the modifiable risk factors, smoking by far is the most important risk factor, which has a definitive association with RCC. Cigarette smoking contains many carcinogens, such as polycyclic aromatic hydrocarbons, beta-naphthylamine, and nicotine. These have a direct nephrotoxic effect, and chronic smoking causes RCC. One large retrospective analysis found current and former smokers to have an 1.5 and 1.6 fold of relative risk of RCC respectively. Obesity has also been associated with development of RCC. It has a consistent association between the body mass index and risk of RCC, much like other neoplasms like CA breast. Obesity promotes resistance to insulin and insulin-like growth factors that facilitates uncontrolled tumor growth. It also releases inflammatory cytokines that disrupts the metabolic homeostasis that leads to overproduction of DNA damaging free radicals, and thus it promotes the pathogenesis of RCC. A study of European prospective investigation into cancer found that high BMI was associated with a 2.25 increased relative risk for RCC. Among diet rich in cruciferous that includes green vegetables have been associated in some studies with a low risk of RCC, while those in heavy meat-based diets that contains large amounts of protein, fat, or dairy are associated with higher risk. But this correlation is not as strong as for other neoplasms. As far as alcohol is concerned, moderate drinking seems to have a slightly protective effect against RCC. Heavy drinking associated with increased risk among both men and women. Hypertension damages the renal glomerulus and tubular apparatus, and it has been associated with increased risk of kidney cancer. It depends on both the time since the hypertension was diagnosed and the severity of hypertension, whether it is controlled or uncontrolled. So, chronic hypertensive patients have an increased risk for development of RCC. Among the drugs, the popular painkiller paracetamol is also associated with RCC, and regular use of non-aspirin NSAIDs have been also have an association. This is likely because they inhibit prostaglandins, which are necessary for proper kidney function. Among occupational exposure, RCC is not traditionally classified as an occupational neoplasm like bladder cancer, but there have been few exposures, few chemicals which have been associated. Most prevalently, trichloroethylene, that is a solvent used in degrazing agents, spray fixatives for art. It has been associated with the development of RCC. The other occupational chemicals include asbestos, benzene, vinyl chloride, herbicides, and cadmium. Now, RCC has a special association with the VHL syndrome. The von Hippel-Leu syndrome is an autosomal dominant disorder that is characterized by multiple tumor types that affects different organ systems with an age-dependent penetrance pattern. Amongst the most frequent tumors are the hemangioblastomas of the retina, clear cell carcinoma of the kidneys, pheochromocytoma, and few pancreatic neuroendocrine tumors. Now, when the RCC is associated with VHL, it has slightly different presentation. Usually, RCC is an old man's disease. It occurs in 6 to 7 decades, but when associated with VHL, the age of onset is 3rd to 5th decade. And usually, we see bilateral RCCs, and there is multifocal involvement. Now, coming to the clinical presentation, incidental finding of a renal mass on abdominal imaging is by far the commonest modes of presentation. Benign renal tumors are an ever-increasing common entity in urology because of the widespread use of abdominal imaging. Over half of renal tumors are found by chance and may have no symptoms at their initial presentations, and tumors found in this way are more likely to be localized to kidney, and they have good outcomes. When presenting with the symptoms, the classic triad of flank pain, hematuria, and palpable abdominal mass, this is not usually present. It is present in about 1/3 of patients because of the increased use of non-invasive imaging for the variety of non-specific symptom complexes, and thus the disease is detected at an earlier and curable stage. However, when this constellation of findings are present, it always denotes the advanced disease, and therefore it is sometimes referred to as too late triad. Other indicators of advanced disease on presentation include the constitutional symptoms such as weight loss, fever, night sweats, malaise. If there is metastatic involvement, the patient can present directly with the systemic involvement. For example, bone pain if it has metastasized to bones, or persistent cough if lung involvement is suspected. One of the rare presentations is spontaneous perirenal hemorrhage, in which underlying mass may be obscured. Mostly an RCC or AML is present, which is diagnosed on a repeat CT after a few months. Then we have a group of symptoms which are grouped together in paraneoplastic syndromes. We will be discussing it in the later slides. Non-presentation physical examination. approximately 30% of the patients of RCC present with metastatic disease. So apart from the general physical examination, the examination should thoroughly evaluation for all the systems for metastatic disease. Particular focus should be made into the examination of lungs, soft tissue, bones, liver, cutaneous sites, and central nervous system, because they all have an association towards the metastatic involvement of RCC. Other important physical findings that are peculiar to this disease may include palpable cervical lymphadenopathy that shows advanced disease. Bilateral lower limb edema can be present that results from IVC involvement. Varicocele, if it's found on right side or a non-reducing left side, points towards a renal mass which has involved the renal vasculature. Now coming to the investigations, as already mentioned that with increasing utilization of imaging studies nowadays, RCC is increasingly detected incidentally as a suspicious mass on abdominal CT scan or ultrasound. Few patients present with symptomatic disease, for example, the gross hematuria, flank mass, or pain. RCC is remarkable for the frequent occurrence of paraneoplastic syndromes, which include the systemic symptoms such as hypercalcemia, erythrocytosis, non-metastatic hepatic dysfunction. Thus, laboratory studies in the evaluation of RCC should include the workup for all neoplastic syndromes. The basic laboratory studies include the all baseline investigation, urine analysis with urine cytology, if a central region or a transitional cell carcinoma is suspected. CBC is checked with the differentials, and polycythemia is also checked because the patient can present with increased erythropoietin. Electrolytes, renal profile, renal function test, serum calcium, and other tests are indicated depending on the patient's presenting symptoms. The basic diagnostic tool in diagnosis and staging of RCC or any renal mass is the imaging. There are a number of imaging modalities which can be used. Contrast enhanced CT scan of the abdomen is considered as gold standard, preferably including the pelvic CT scan. If CT scan is not available or there is contrast allergy, then the alternate to it is a MRI. Ultrasound is initially used or can be used, for example, if incidental finding is found on ultrasound. Chest CT scan or chest X-ray is used for if metastatic involvement is suspected. Renal arteriography and venography was used previously for involvement of renal arteries and vessels, but now it has largely been replaced by magnetic resonance angiography. And if any metastatic involvement is suspected to bones, then bone scan can be performed. Similarly, brain CT or MRI can be performed if clinical manifestations suggest brain metastasis. PET scan, the role of PET scan remains controversial. It is not usually considered first line or for the diagnosis of renal mass or RCC. However, if any other tumor has metastasized to kidney, then a PET scan has a role and it can detect the metastatic lesions in the kidney. The few images of the cross-sectional image of the CT scans. For example, this is the image of a right-sided angiomyolipoma. They usually present as marginated cortical heterogeneous tumors with house-filled units of less than 10-20. And house-filled units of less than 20 are widely accepted as confirming or diagnosing the angiomyolipoma. This image shows a left-sided renal tumor, and it is the finding of a left-sided oncocytoma. A potential helpful sign in this is the presence of a central stellate scar, which is characteristic for oncocytoma, but it is present in 1/3 of the patients. And this is the image of a left-sided renal cell carcinoma. RCC typically show arterial enhancement. Centrally necrotic patch is visible. In general, small lesions, they enhance homogeneously, while the larger lesions have irregular enhancement on the arterial phases. The clear cell subtype may show much stronger enhancement than the other variants. Now coming to the paraneoplastic syndromes, Paraneoplastic syndromes are rare disorders that are triggered by altered immune system in response to a neoplasm. They are defined as clinical syndromes involving non-metastatic systemic effects. Considering the pathophysiology, they are thought to happen with cancer-fighting antibodies that are the T lymphocytes. They mistakenly attack normal cells in the nervous system. So the disorders typically affect middle-aged to older people. Specifically, paraneoplastic syndromes, when associated with RCC, they are found in 10 to 20 patients of RCC, and very few non-renal malignancies are associated with a similar quantity and diversity of such syndromes. In fact, RCC was previously referred to as internist tumor because of the predominance of systemic symptoms rather than local manifestations. These syndromes are more common in metastatic disease and very less common in the patients who have diagnosed incidental renal masses. Amongst these, a common finding is elevated ESR levels. They are found in more than 50 patients of 50% patients of such syndrome. The usual associations with in RCC, they include most likely hypercalcemia. It occurs due to overproduction of 1,25-dihydroxycholecalciferol. It is reported in about 13% patients with RCC. It can be due to paraneoplastic syndrome or metastatic involvement of the bone. The metastatic involvement must be ruled out before labeling it as a paraneoplastic phenomena. Hypercalcemia, when symptomatic, its medical management includes vigorous hydration followed by diuresis and bisphosphonate therapy that is considered as a standard of care in such patients. The definitive treatment includes nephrectomy and occasionally metastatectomy, which leads to the resolution of hypercalcemia.
Just a word of caution here, because whenever you are dealing with RCC, if you are looking for anything which is paraneoplastic, most of the times you can't find many of these things. So it's not necessary that these conditions like hypercalcemia and others, they are tagged to every case of RCC. One thing. The second thing is, as you have mentioned in your previous slides about the diagnostic workup of RCC, it can give somebody a wrong message. For instance, if you have put something like PET scan on the slide without any reference, and if this thing is at the back of the mind of somebody who is a very junior person, that carries a negative marking, because this is not part of any protocol. This is not part of any guideline still. So you see, whenever you use any new technology for any kind of diagnostic workup, it has to have a reference. Otherwise, everything is on the table. You can pick and choose anything, but that won't be something which is of standard value, right? So you can discuss the pros and cons, but whenever you are speaking from the podium in a classroom, then the message has to be very clear. It has to be 100%. Now, still, a PET scan is not on the cards for RCC.
So for detecting secondary, that the metastatic...
That's a separate question. But for diagnosing a primary tumor, RCC, PET scan, for instance, what the message nowadays is in Pakistan, if there is a thing called PET scan in any center, any city, somebody comes to you in the clinic and says that I have got a feeling that my weight is losing, so please do a CT scan and probably a PET scan, so that from head to toe, something which is hidden should come up, because there must be something which is turning into malignancy. So this is the kind of medicine that actually is being propagated not by the public, but by us. So please be sure, whatever you say from your mouth, it should be a statement of value, right? हम उस पर discuss कर सकते हैं कि what are the pros and cons of any new technology. लेकिन जब तक कि वो उसकी validated studies नहीं हो जाए ना, वो किसी guideline का हिस्सा नहीं बन जाए, आप उसको ना यहाँ discuss करेंगे, वो बाकी चीजें भूल जाएगा बंदा. वो सबसे पहले बोलेगा मैं इसका करूंगा जी for metastasis और probably thrombosis देखने के लिए MRA, which is not available in Pakistan. in many centers. I don't know whether it is available in our city or not, but at least not in our center. And जो दूसरी चीज़ वो बोलेगा पेट स्कैन, वो चीज़ें नहीं बोलेगा जो कि सबसे कॉमन है. सो आप कॉमनैलिटी से स्टार्ट करें, आप अपने जहन को उस अंदाज से प्रिपेयर करें कि वो आपको इजी बनाए प्रैक्टिस करने के लिए. ठीक है, अभी कंट्रोवर्सीज पे ना पड़े. एट योर लेवल you should not go into controversies.
For every case.
And very
Even
soon, sir.
EAU, I was right,
Ji.
Reading EAU last night. So even MRI is indicated when there is a doubt in CT scan. So CT scan is the gold standard, as you rightly said. But why MRI? Then it was justification by that when there is a doubt in CT, then you go for MRI, not for every case.
And why I'm just stressing this thing, because very soon we'll be starting this PET CT scan in our unit in Sakhar. So there will be an onslaught of patients to you, GM and Sabur Saab, because they will be asking you to do PET without doing anything else, without doing ultrasound, for instance. And if you do PET for each and every patient, you will have a havoc, and you can't explain why you are doing PET or why you are not doing PET. So PET is not something which is a pet. I mean, it's not a pet like a pet dog. It's something which has got a scientific basis. So first, we all must clear our scientific knowledge, and whenever there is something which is available in terms of guideline, it has got its place, then yes, it has to be done, and we'll be the first ones in our country that will do in public sector, perhaps. So that's a plus point that we have, but please don't make it a negative point. Sabur Saab, I'm talking to you here. So you have a very great responsibility, because you will be starting PET in that part of the world where nobody is having it.
Agreed, sir.
Agreed.
The second association in paraneoplastic syndrome is hypertension. This is due to increased production of renin directly from the tumor, or it can also occur due to compression or encasement of renal artery that leads to renal artery stenosis. Hypertension has to be dealt accordingly, but ultimately it resolves when the primary disease or the RCC has been cured. Polycythemia association with RCC is due to increased production of erythropoietin, and it can be either directly from the tumor or by the adjacent parenchyma, which is in response to the hypoxemia induced by the tumor growth. Stoffer syndrome is an interesting association of paraneoplastic syndrome. It is a non-metastatic hepatic dysfunction which has been reported in few cases. Labs show elevated alkaline phosphatase levels, elevated PT levels, hypoalbuminemia. 20 to 30% of patients have serum bilirubin and transaminase levels increased as well. Liver biopsy in such cases shows no non-specific hepatitis in discrete regions of necrosis. Nephrectomy usually leads to resolution of hepatic dysfunction. If after nephrectomy there is persistence or recurrence of dysfunction, it almost always indicates a viable tumor and thus shows poor prognosis.
So a word about Stoffer syndrome. Whenever you have got a patient with deranged LFTs, unless and until you prove that there is no metastasis to the liver, unless and until you prove that there is nothing called viral load that causes hepatitis, you can't just put that patient into Stoffer syndrome. Why I'm stressing this point? Because many of the cases are put into the wastebasket of Stoffer syndrome, and then they are operated. And when they are operated, what happens is many of these anesthetic agents, they do cause some kind of a liver problem. And the patient after operation in the post-operative period, particularly in the early post-operative period, they have got a problem with liver dysfunction in having elevated enzyme levels. So whenever you come across with a patient with a combination of a renal tumor and a liver dysfunction, just put that patient on a long haul, do a little bit of an exercise, and see what's happening with the liver first. Try to consult with your colleagues in the hepatic department, in the liver department, GI department, and try to sort this thing out. Don't put your patient directly onto the list, because we have seen, and Murli Sahib is also seeing all these cases. Many of these cases, why these cases are having liver dysfunction in the early first 24 hours after operation, and many of these cases are renal tumor cases. So we have to go back and search our souls. There is something which is going on. Maybe we are too fast. Maybe we are just ignoring this kind of an association.
There are a variety of few other less common distinct perineoplastic syndromes association: Cushing syndrome, hyperglycemia, galacturia, clotting disorders, cerebellar ataxia, but these are very rare, and all the other associations have to be excluded before labeling it as perineoplastic syndrome. In general, treatment of perineoplastic syndrome associated with RCC has required surgical excision for the initial stages or systemic antineoplastic therapy if it is in stage 4. Except for hyperglycemia, medical therapies have not been proved helpful for other associations. Now coming to the staging workup of renal cell carcinoma, the international TNM staging system is considered the gold standard, and only this is used now. Previously, there had been few other systems like Robson system, but they all had limitations. So now only the TNM system is used, which is explained here. In the primary tumor, Tx would be considered as the tumor cannot be assessed. T0 is no evidence of primary tumor. T1 and T2, the tumor is limited to kidney. In T1, it is less than 7 centimeter in greatest dimension, and in T2, it is more than 7 centimeter but limited to kidney. T3 would be called when tumor extends into major veins or directly involves the adrenal gland or perinephric tissue but not beyond Gerota's fascia. In T3A, it involves adrenal gland or perinephric tissue. In T3B, the renal veins or its branches have been included, but it is below the diaphragm. In T3C, it extends the IVC above the diaphragm. And in T4, it directly involves beyond Gerota's fascia, and it can include the distant metastasis. Regional lymph nodes, N-X is when it cannot be assessed, and 0, no regional lymph node metastasis, and where metastasis in a single regional lymph node, in N2 is metastasis in more than one lymph node. Similarly, in considering to M0 is no distant metastasis, and M1 where distant metastasis is found. So staging is done accordingly with stage 1 referring to T1, N0, M0 stage 2 is T2. In stage 3, we can have T3 without any nodal or metastatic involvement. But even if single group of lymph node is involved with either T1, T2 or T3, it would be included in stage T3. In stage 4, it would be T4, and the nodal involvement and metastatic involvement can vary, but it has to be T4.
Now, practically, this TNM classification is actually has got a little bit of space for another thing. So it is rather incomplete. Incomplete in the sense that, for instance, if you are talking about a thrombus, and which you are actually depicting on the diagram, then you also must consider the level of thrombus, which is not considered in any of the staging processes. It has got its own practical value. For instance, if the tumor thrombus is staged, then there is something attached to it. Maybe it is the comfort level of the surgeon and the kind of procedure that the surgeon is actually employing to remove the thrombus, because whenever there is thrombus, you have to do thrombectomy. So a level 1 thrombus or a level 2 thrombus or a level 3 thrombus and a level 4 thrombus. these thrombi, they pose a different kind of a technical problem. So GM, would you like to say something about this additional problem which is not addressed by the staging process? Because the staging process actually is there to help you in planning management.
Yes, sir. Exactly agreed with the with this point of staging deficit in this. But when we are reading the text regarding this topic, it tells there that when there is a stage 3 tumor with uh, thrombus into the IVC or renal vein, then this will be stage 3 and will not have much more impact on the prognosis of that disease towards the upper staging. But simultaneously, it is also written over there that there are two types of thrombus. One is floating thrombus, and other is the thrombus which is involving cancer thrombus, which is involving to the wall of the IVC and above up to the heart. And that's an involvement of the wall of the IVC will have poorest prognosis in that case. But these things are not included in the TNM classification system, and definitely I agree with you that this is the deficit of this classification.
Because you have got two separate issues attached to it, and these issues have to be solved in very soon. And these two issues are, one, the kind of imaging which is needed to delineate whether this is a floating thrombus or this is a thrombus which has invaded the wall of IVC or the renal vein, because that changes the stage. One thing that can be seen on maybe CT angiogram, or more so by MR angiography. So they can give you a clear picture whether the thrombus is actually enhancing on post-contrast films, and also whether the wall is involved or not. One thing. The second thing is, whenever you have got a kind of a planning for these tumors, now you have got tools. You have got tools like robot, for instance, and robot is actually manufactured or designed to give you an access to an area which is narrow. Now, the narrow access are two areas in the body. One is just below the rib cage, where you have to tilt your body and your neck and see just below the rib cage. You have to lift the rib cage up by means of separate kind of say retractors, and these are special retractors that tend to tent up the rib cage in order to give you an access towards the area which is below the liver. The second axis, the narrow axis, is in the pelvis. So you see, robot has got its value not in between, but more so in these two areas. For these tumors, and there are centers and people like Inderbir Gill who are doing surgeries for stage 4 and 3 thrombi. So they deliberately incise the sternum, they do the sternotomy, go into directly into the thoracic part of IVC and take out the thrombus from the IVC. Now for that kind of maneuvering, you need a different kind of a picture, and that picture is provided by MR angiography. So if that is the way forward for any kind of surgical group with a tool in his hand, and we have got that tool in our setup now, the thinking and the planning has to be on that level. You see what I'm stressing it. I'm stressing the point that you should not be satisfied with this kind of staging process. Now, everything in science has got a kind of a beauty in the sense that you can always modify it to your say comfort. So this staging process is not that final staging process. It will change. It has to be changed because it is not giving you that kind of information which will provide you the kind of planning which is needed for such tumors. So there is now a lot of hope for those cases who have got tumor thrombi beyond stage level 1 or level 2. So that's my point here. Yes, sir.
Exactly, agreed, sir.
This is a brief summary of stage-wise treatment of RCC in stage 1 and 2. Partial nephrectomy or radical nephrectomy can be done depending upon the exact size and precise anatomical location. Stage 3, we go for radical nephrectomy. It may need vascular cardiac surgeon depending upon the extent of vascular involvement. And in stage 4, immunotherapy and targeted therapy has done. Radical nephrectomy may be performed in stage 4 as well, but it is never curative. The detailed treatment of RCC, it would be discussed in the next sessions.
Regarding this treatment of RCC, can anyone explain when we will be needing nephrectomy in these stage 4 diseases? Anyone from PGs over there?
You can ask someone from your point, from your place. I think there are 3 PGs behind you.
Dr. Usman is senior most.
Yes, Usman can pick the microphone and say something.
So we can perform in stage 4 disease, we perform palliative nephrectomy in case there is some obstruction. To decrease the burden of the disease.
Dr. Fayaz?
We can perform radical nephrectomy in stage 4 for paraneoplastic syndrome symptoms to reduce the symptoms of paraneoplastic syndrome.
There is a word.
Sir,
There is a word
sir,
called cytoreductive surgery. So, what that word means, Fayaz, आप जरा स्क्रीन पे आ जाएं, आप चुप रहें. So, what is cytoreductive surgery?
Cytoreductive surgery means reduce burden of tumor.
चलें, ठीक है.
Sir,
You-
first,
Usama.
yes, sir. First we, in case of stage 4 disease or metastatic disease, first we have to risk stratify that patient according to the IMDC or MSKC staging system. And in that system, if the patient falls into the good risk category and if he does not require any systemic therapy, in that case we can offer him cytoreductive nephrectomy. If he lies in the intermediate or poor risk on IMDC and MSKC system, we must offer him the immunotherapy or the targeted therapy. In that patient, there is very less role of cytoreductive nephrectomy.
So,
Exactly. What other indications when we will be needing nephrectomy in these patients when we can do targeted therapy in metastatic disease?
Sir, if there is a persistent or intractable hematuria, then we can offer him in nephrectomy in these patients. That is only for palliative reason. And if there is intractable pain, intractable hematuria.
can you say something about Carmina trial?
Yes, sir. Carmina trial has been done, which is a comparative trial, and it compared the patient with nephrectomy and TKI, and the other arm contained only the TKI. And that trial have shown that the patient, there is non-inferiority trial. There is no advantage of cytoreductive nephrectomy plus TKI or TKI only. So this trial does not show superiority of cytoreductive nephrectomy plus TKI or TKI only.
So, in simpler terms, what would you suggest? You should, whenever you have got a metastatic RCC, you should start with immunotherapy first or targeted therapy, or you should have cytoreductive surgery combined with immunotherapy. What do you say?
Sir, first we must counsel the patient what he wants to have, and if he's a good performance status, then
I mean, he wants to believe in the kind of trials that are going on. If the person is a very educated person, so the trials has to be understood by you first, and then you can advocate anything which is there in the trial, in the conclusion of the trial. Right, sir.
So the last section of today's presentation is about the renal mass biopsy. Percutaneous image guided biopsy of a renal mass is safe and accurate procedure. Once reserved for diagnosis of unresectable RCC, metastasis, lymphoma, and infection, Today, the biopsies has an expanded role. There's an increased awareness that a substantial portion of small, solid renal masses are benign neoplasms. And although imaging can be used to diagnose most of them, some are incorrectly believed to RCC and unnecessary surgery can be avoided. What are the indications of renal mass biopsy according to the European Association of Urology 2020 guidelines? The following 4 indications in which a renal mass biopsy should be performed. Number 1, to obtain histology of radiologically indeterminate renal masses. To select patients with small renal masses for active surveillance. To obtain histology before or simultaneously with ablative treatments. And select the most suitable form of medical and surgical strategy in the setting of a metastatic disease. A renal biopsy is not indicated for comorbid and frail patients who can be considered only for conservative management, regardless of the biopsy results.
So what's the definition of a small renal mass? How small is a small renal mass?
So it should be in stage T1 or T2, confined to the kidney.
So if it is a 7 centimeter mass confined to the kidney, is it a small renal mass? GM, what do you say?
Yes, sir. When tumors are smaller, then we will suspect that these tumors can be benign or can be malignant. In that setting, we will have to determine the histology of these cases when we are not surgically approaching these cases. So it will not be 7 or stage 1 or stage 2, but rather 2 centimeter or less tumors are being kept on surveillance. And for that, we may need biopsy, so that we should be sure that this is benign or they are not malignant.
My question was, what is the cutoff of a small renal mass?
So
Less than 4 centimeter?
2 centimeter is the size, not the 4 centimeter.
Reference? What's the reference? Giusama, reference?
I can't recall at this time. But, I have read from guideline, but I'm not sure at this time for the reference. Recall it.
Because if this is a less than 2 centimeter mass, radiologist will just ask the patient to go back to the clinician because he can't do it. So how would you do a biopsy of a less than 2 centimeter mass? जाके देखिए, सब लोग देखिए जाके, ये छोटी सी चीज है, कहने को तो आपने ले दी, स्टेटमेंट दे दी, और 2020 गाइडलाइन तो आपने कह तो दिया, अगर ब्रैकेट में लिख देते कि उसकी साइज क्या था. ठीक है. So in Guy's Hospital in England, there is a separate clinic which is a clinic for small renal masses. So these small renal masses is not something which is only a differentiation of a malignancy and maybe a benign condition. There is a lot of debate going on how these masses should be followed. So whenever you have got a mass which is less than 4 centimeter, and that is their criteria, that is not the guidelines criteria, they ask the patient to go to the separate clinic, and that is a clinic for small renal masses. And they do biopsy for all these masses. If they turn out to have, for instance, RCC, less than 4 centimeter, they refer the patient back to the same unit and ask the colleague to do maybe partial nephrectomy, robotically assisted. So this is the kind of algorithm that they follow. And if, for instance, if the mass biopsy turns out to be for maybe oncocytoma, or other benign condition, then those cases are followed up. They are on a longer follow-up. But they don't ask the patient to just come in one time and then go away, don't come again. That is not the case. They have to follow these cases maybe up to the level of 60 years or 70 years. There's a criteria. So they have got their own algorithm for managing these patients.
So briefly about the procedure of renal mass biopsy that can be performed as an outpatient procedure. However, it is usually done in radiology department because it is usually done with help of ultrasound or CT scan. It can be, there are two types of biopsies, a percutaneous biopsy or an open surgical biopsy. A percutaneous biopsy is the most common type of biopsy performed. A thin biopsy needle is introduced through the skin to remove the tissue from renal mass under the radiological guidance. And in open surgical biopsy, we make a cut in the skin near the kidneys to determine this area from which the required samples are taken. The guidance modality that depicts the lay-in or adjacent structures and the needle tip, that the best guidance modality that should be used to guide the biopsy. Each modality has its advantages and disadvantages. Ultrasound is we can perform bedside, it's readily available. It provides real-time imaging without ionizing radiation. It can be done in pregnant women, but sometimes it may not visualize the lay-in. CT is more expensive, however, it usually allows better depiction of the mass and surrounding structures. MR is seldomly used but may be helpful in the biopsy of a mass which is not seen by ultrasound or CT scan. Operator preference and equipment availability will definitely play its part in deciding the modality. Typically, fine needle or large needle both can be used for the histology. Comparison of both have been done. The fine needles have been shown to obtain a diagnosis in up to 93% of masses, and high rates of success has also been reported in studies in which only large needles were used. But large needles may be more effective, but probably carry a higher risk of bleeding and pseudoaneurysm formation comparative to fine needles. Overall, however, renal mass biopsy is a safe procedure, and most hemorrhages are subclinical and self-limited. And the biopsy results should have implications on patient management. Therefore, obtaining a benign diagnosis is as important as obtaining a malignant one. The absence of malignant cells from biopsy, however, does not necessarily confirm the benign nature of disease and should be viewed with caution. Sensitivity of biopsy for benign diseases is 80 to 92%, and specificity approaches from 83 to 100%. False negative results are likely to occur due to inaccurate needle placement or obtaining some necrotic tissue. False positive results are, however, rare and they are much less frequent due to advances in cytology. Complications, the major complication is bleeding. If considered of hematoma, it is formed in 4.9% of patients. Gross hematuria is 1%, and hemorrhage requiring transfusion is very less, that is 0.4%. Then clinically significant pain or pneumothorax is also associated, that is very less frequent with biopsies. And pseudoaneurysm can also be formed. Overall, however, renal mass biopsy is a safe procedure. Most hemorrhages are subclinical and can be self-limited, and they can be managed conservatively. That's it.
So, if anyone has any question to ask for any in this presentation from the PGs and
GM, you just summarize because now this is beyond 9 o'clock.
yes, this was a core study presentation regarding the renal cell carcinoma. It's initial awareness like investigation, symptomatology, and most importantly, pathophysiology. Pathophysiology of RCC is most important topic to be studied because more and more treatment is going towards neoadjuvant treatment in RCC and metastatic diseases. We are treating it medically. So pathophysiology is very much important in understanding these neoadjuvant treatment and metastatic disease medical treatment in RCC, because that targeted therapy directly targets over the pathophysiology, or when this tumor is occurring in related to VHL gene or in any form like sporadic and hereditary types of RCC. This pathophysiology of this disease is related with mutation in most commonly in mutation in VHL gene, which is causing hypoxia-inducing factor and overgrowth of vascular system and upregulation of cell division, which is causing tumor formation. And these drugs, which usually are being used, are directly targeting over this hypoxia-inducing factors. So if we don't know clear pathophysiology of this development of this RCC, then we cannot understand the treatment and treatment modalities which are high in this market nowadays. And other thing is RCC is a clearly very better to understand on imaging contrast on CT scan. So this is also a hot topic to understand how radiologically RCC is confirmed as a diagnosis of RCC. So, this is all about all about this disease. So best of luck of all.
Right. Thank you very much. Thank you.